Our next presentation is S071, Validity Evidence for the Fundamentals of Laparoscopic Surgery Program as an Assessment Tool, a Systematic Review, to be presented by Dr. Zendejas.
Good afternoon. Let's see. We have nothing to disclose. This is an audience that does not need a formal introduction on what the fundamentals of laparoscopic surgery is. We've all seen these tasks, and many of us have practiced and developed many of these tasks and used them quite often during our training and our academic practices. And it's pretty clear that several studies have proven its robust training effectiveness. However, for us, it became a bit also an interest in research that the assessment portion of this FLS had received, at least it was our perception, less of a research emphasis with compared to its training effectiveness, particularly when we look at the knowledge and skills, and we'll talk a little bit into that. And this was important for us because it's been used as a high-stakes assessment, as we've talked before, most of our general surgery residents have to be eligible to take their boards after passing this, and therefore we have to ask ourselves whether the scores or inferences that come from these assessments are valid and reliable. For this reason, we undertook a systematic review of the published evidence to try to identify the sources of the validity evidence, to identify the validity argument and make sure that there are any gaps that need to be addressed. We performed a systematic review of all the standard databases online for any studies that were published before March 2013, so I apologize if your study was published after that. It's not included in this systematic review. We particularly focused on the papers that presented new validity evidence and did not just refer to older validity evidence that has been reported previously. We particularly paid emphasis to put the context of the evidence into what the currently accepted framework for validity, which is MESIC's framework that's been adopted since 1999 and further reinforced in the 2014 standard statement from the American Association for Education Research and the National Council for Measurement in Education. And basically what MESIC proposed is that all validity is validity, and that the 5 sources of validity evidence described here, content, response process, internal structure, relation to other variables, and consequences, what they do is to formulate a validity argument to be able to interpret these scores. We began with approximately 11,000 or so manuscripts. After careful review, we identified 23 studies that included 1,280 participants that were the focus of this study. The inter-rater agreement, because this was duplicate coding, both for the study selection and for the assessment of the validity evidence, was fairly adequate, from 0.67 to 0.91. This is a reflection of the different type of participants that were included in these studies. We can see it was quite varied, from medical students to postgraduate trainees, as well as practicing physicians. We also saw that the predominance, as expected, was in surgical disciplines, a few in obstetrics, and even one study in veterinary medicine. This is, for the most part, the main study slide, and what it gives you is the distribution or the prevalence of validity evidence sources. You can see how predominantly relations to other variables has been the focus of most of these studies, a few with unfavorable evidence, meaning that doesn't really support in certain circumstances. And we'll talk about that, but the overall very supportive evidence, fewer for the content, internal structure, response process, and consequences, and we'll go into each of these in detail. This is the, sorry for the busy slide, but this is just to give you an idea how there were some studies that reported both favorable and unfavorable evidence, as reported by the green and red markers there. And some studies reported only one source of validity evidence, while others reported multiple sources. When we dig deeper into content evidence, we saw particularly 2 studies that described what the content of the assessment itself meant. And we see these are 2 examples of what they mean. The tasks were determined by the consensus of 5 expert laparoscopic surgeons, for example, or the comment where the scores were standardized against the performance of surgery chief residents and then later normalized so that they would range from 1 to 100. For internal structure, we found 3 studies that predominantly looked at reliability. These were the main reliability indices that were looked at, and fairly good in inter-class correlation coefficients, all above 0.77. Relations with other variables, as I said, this was a predominant area of research in the field, primarily looking at differences in levels of expertise. as well as sensitivity to change, whether the scores improve with training or not, and other factors also. Also interestingly was these correlations with other assessments, both simulation-based training and non-simulation tools, such as in-training exams, as well as operative performance rating measures, as well as automated metrics like motion analysis, like in our previous presentation. Response process has to do more with the raters, and so therefore 2 studies have talked about rater training, blinded video review of rating accuracy, and then rater retraining as needed. Consequences. Unfortunately, we did not find any study that looked at the intended or unintended consequences of testing with the FLS. An indirect measure of consequence evidence is the pass-fail threshold, and these were all established with the receiver operating curve methodology. We looked particularly at each task in and of itself as how it related to the total FLS scores. And for the most part, every single task has very good discriminatory and correlational characteristics that are similar to the total scores, except that we found that the ligating loop, there were several studies that did not consistently support its discriminatory ability. For the knowledge component assessment, fewer evidence in this area. The content, internal consistency, fairly good, but the relationship to other variables, there were 2 studies and they each showed mixed results. One was very supportive and the other one showed that it did not apply really to obstetrics and gynecologic surgeons. So in summary, though we have come really far and have advanced a lot in FLS assessment, I still think there's work that needs to be done. I think there are a few gaps in the evidence framework as highlighted here where I think we need to pay emphasis on a little bit in content, response process, and consequences. I think that the evidence is skewed towards relationship to variables, and you might ask yourself, well, we have a lot of relationship to other variables, isn't that not enough? Well, the truth is that strong evidence from one source really doesn't compensate for lack of evidence to the other sources. They each complement each other, and they should be building blocks for this argument. And I think the ligating loop task is the most expensive of all the tasks, and therefore, if it doesn't consistently show discriminatory ability, we should ponder whether its value adds substantially to this assessment or not. And with that in mind, I'd be happy to answer any questions. Thank you.
Yes.
Hi, Matt Ritter from Walter Reed. Thank you for a nicely presented study using the modern unified theory of validity. It's nice to see that gaining popularity and being used correctly. I agree with many of your statements in terms of reasonable evidence across the 5 areas of validity evidence for FLS. However, I guess I would come to a different conclusion with that, and I'd be interested in your thoughts. Of the other required assessments that the American Board of Surgery, have you found any others that have this level of published validity evidence? I mean, a lot of this is in internal psychometric documentation, but to have this level of published validity evidence for an exam, my conclusion would just be that's more of a goal for others, and we continue to work on that, but I think that this has more than those other things out there, and be interested in your thoughts.
I agree completely with your assessment. I think there's no other assessment instrument out there for simulation-based training that has this amount of validity evidence out there. I agree that, I mean, even at this session, we heard a great response process evidence that was presented by our colleagues here with the rater distance assessment, so that's evidence for response process, and so we continue to work on that to be able to balance the assessment argument, so yes.
First of all, I want to congratulate you also on a beautifully presented study. I think one of the great things about FLS is it's taught us a lot about education and assessment, and that it's a very, very nice model to be able to develop these types of skills as surgical educators to ensure, and I don't think we can go through the process of establishing this level of evidence for everything we want to use for evaluation, or we're just going to be too logjam. But it's a great model for these types of research studies that really embed in us as a surgical specialty society with an education bent to do this type of work. And I think that studies such as yours call to our attention the methodology and the way we should go about it, and I congratulate you. Thank you.
Thank you for your comment, Dr. Fried.
Thank you.
Hi, can I, is
Yes.
there enough time? So while you were presenting, it got me thinking, and it's more just a comment that I think, and I agree with what the two previous commenters mentioned, that we're learning a lot more about validity and how to acquire validity through FLS. And I think we need to broaden a little bit the way that we decide whether or not there's evidence for validity. Like, in particular, the fact that FLS has now been around for so many years, that it's been used in so many different ways, that it's been adopted by the American Board of Surgery, that it is now being used all over the world. All of this suggests that there are experts who find that it has value and that it represents something that's important to them about education. And we are not really looking at that as evidence for validity, but I think that that does represent evidence for validity of the assessment. And the other thing is that I think a lot of these studies were done in the past, and I think it's a good idea to relook at this, because it could be that that evidence existed then and that it may be different now. And so all of these things are not static, and I think it's a good reminder for all of us that when we're looking at any assessment, we have to reevaluate that and see if it's current for our needs now, because time is also one component of that.
Correct.
So,
Those
thanks.
are two excellent remarks. I think that I agree completely with them. I think that we are looking into previously published data with a new framework in mind when at the time they were using a different framework, so it might not fit completely. And just for the sakes of the rigor of the systematic review, it's very hard to tangibly measure the impact of what you were talking about. I mean, how it's been adopted by so many instances, and so that's just hard to put it into a systematic review. But we all know that it's been adopted quite well. Thank you.
Thank you. Nicely presented.
Thanks.